Dear audience, it's my pleasure to be with you again with this course, 15 minutes, doing the unconventional in keratoconus treatment or beside the keratoconus management. Again with you, Elias Jarede from Lebanon. Well, taking the interventional part, cross-linking, PRK, and ring phakic IOL cornea graft as well in keratoconus. What we do as unconventional, first we like to mention the cross-linking using the femtosecond entrelace to create a pocket in the cornea and then injecting the riboflavin directly inside the stroma and doing the UV light. This has a quite an advantage, keeping the epithelium intact, decrease all aspect of complication after cross-linking, and shorten quite a lot the period of rehabilitation after cross-linking. Here showing the different stage. We use the spiral technique with the reverse cut hinge ratio to create a small opening to the pocket, dissecting it, inject the riboflavin, then use the UV light exposure. He's showing the video brief using the spiral technique. Worth mentioning that we start this technique quite earlier than having the entrelace, having the pocket algorithm to create a pocket with an entrance. We use at that time, before that algorithm, we use the reverse hinge cut ratio to create a small opening, injecting riboflavin inside the cornea after dissecting and doing the UV light exposure. We start this technique in 2007. Until now, we have good stability of the cornea and very satisfactory result. Definitely with the advantage of having no pain, rapid recovery, and less risk of scar, infection, inflammation, etc. Here's showing a case of pocket formation, showing the edges of the pocket, riboflavin with the haze of the cornea, preparing this patient for the ICL. Another things doing unconventional is doing the soft contact lens in thin cornea. In such case, we have thin cornea with the scenario that we cannot do something else because of heavy vascularization, because of allergic, long-standing allergy. We do remove the epithelium before applying the UV light. We apply soft contact lens to artificially enhance the thickness of the cornea and decrease the level of UV light at the level of endothelium, and hence protecting the endothelium against any damage from the UV light. Worth mentioning that we started this technique in 2010 as well. We're having good results. In the unconventional, in the cross-linking or stabilizing the cornea, it's post-ectasia, because our study have shown that cross-linking, the conventional cross-linking post-ectasia doesn't work well with a recurrence, with a progression rate more than 22% over 5 years follow-up. That's why we come up with the technique that inducing fibrogenesis, vertical fibrogenesis, to re-anchor the flap to the underneath stroma and reintegrate the biomechanical forces of the cornea. The idea stems from our observation that in some flap, whenever they have a penetrating trauma or partial trauma, non-penetrating trauma to the cornea, with the event that we tried to lift the flap, we couldn't lift it because of the anchored vertical fibrosis from the previous trauma. We used this observation to come up with the idea, why not puncturing the cornea vertically through the flap to induce vertical fibrogenesis and re-anchor the epithelium, which is a biomechanically considered as dead tissue. Here we can see in the right side that in the left side, we use a diamond blade set at the desired depth, 350 to 400, depends on the peripheral thickness. On the right side, we're using a bended needle to do it puncturing. I think bended needle is better because it induces more fibrosis, more traumatizing, and we can use it as well simultaneously with the ring implantation. Showing the instrumentation of this technique is quite simple, and we can use direct visualization of the cornea topography to localize the steepening area of ectasia and do more function at that area. Here showing the corneal OCT with the quite induced fibrosis, vertical fibrosis. Here showing this slide that at the edge of the flap, how is it reintegrated back with the underneath stroma, and we have very good result in this technique with good stability of the cornea. and sometimes quite significant flattening of the cornea. Here showing a case as well, the function, how does it look like after ring implantation as well. Well, in the ring, what we have done in conventional, based on our understanding of the ring, that ring has to be implanted underneath the steep zone to induce more flattening and enhance regularity of the cornea and increase the corrected distance visual acuity. This is based on our understanding of the cone, which resembles an oblique cone. When it's cut to produce an ellipse, that's how we do believe, and the ellipse has two parts, one flat and one steep, and the ring, whenever it's implanted under the steep part, it induces more flattening, and perhaps if implanted in the flat part of the ellipse, it may do reverse effect. So our topography guided topography, which is concluded from our understanding, implies that the steep ring, the thick ring has to be implanted under the steep area. Looking at this part with the very unconventional polypseudo-like keratoconus, low corrected distance visual acuity, whenever we plan to correct, to implant a ring, it has to be under the steep zone. How we do this? This is our planning, which is drone planning. That's always I do it. I draw my plan before I do it. So we use the entrelace applanation. We figure out where the center of the cornea. Then we shift the center toward the first axis. Then we create another center toward the second axis. And we did two entrelace cut, one centered over the first oblique and then the second centered over the second oblique. We call this double bridle Carter technique. We implant one ring here and one ring here. This is how showing the entrelace cut. This is the symmetric center of the cornea. We shifted the first cut with the same applanation, we did not change applanation. Then we create another cut centered at this part, and we create one tunnel here, one tunnel here to be implanted by the ring. Here showing the two ring implanted at the two steep axis of the polypseudo-like keratoconus. With the extreme remodeling, in some cases where we cannot do more than do the more surgery, like a graft, certain circumstances, patient refuse the graft, or we have high risk of graft rejection. We have nothing to do, but we go with extreme remodeling. In such case, we went to implant two adjacent ring under the steep zone of the cornea. Using the entrelace, we do two concentric cut at two different levels. We make a two different level with some spare tissue between the two tunnels to prevent migration. We implanted the outer ring anteriorly at the steep zone. After that, we implanted here the intacs, the old intacs, then followed by implantation of Kera-ring, the SI5 internally. That's why we did a coupling technique, that the outer one coupling the inner one. And in this technique as well, I inserted one opposite one ring intacs 6.8, 8.3 in the upper part. The aim was to correct as much as we can irregularities, and at the same time spherical equivalent of the power of the eye. Here, after implanting the outer and inner, then I implanted the superior one. Here, how it shows 1, 2, and 3 ring at the same time. Worth mentioning that we have done this technique in 2008. We have more than 12 years follow-up, and the cornea quite tolerating the 3 rings without any sign of melting, migration, or inflammation. Well, moreover, here another case using the intacs SK with the Kera ring. They are more close to each other, but we have more effect as well in such cases. 3 ring, 1, 2, and 3. Morton cuddling in cases where we have advanced keratoconus in the right eye. He underwent graft with the graft rejection. He came years later. Definitely, he used to do graft in the left eye, which is more advanced keratoconus. But we went here, the elevation map of the left eye, showing how much the cornea is distorted with hyperopic shift because of the corneal multifocality and of the prismatic effect of the cornea. How we believe that which led to hyperopic shift in the refraction. Again, bottom line is highly distorted cornea. We put a plan to do 1 210 Kera ring SI5 internally and 1 intacs superiorly. We call this the Wonder Bra technique. We're using the same entrelays with the same applanation, one internal tunnel and one external tunnel at two different depth, not too much away from each other, with some spare interval. We inserted the external intact, then the internal SI 5 to 110 degrees. Well, here, surprisingly, showing the result post-operatively of the cornea with the elevation map with pretty much enhancement of the corrected and uncorrected distal acuity with quite satisfaction from the patient and for the surgeon as well. Another extreme planning for ectasia treatment after implanting two Kera-ring Si5 in a patient with ectasia and a good corrected distance visual acuity with good enhancement of the vision, corrected and uncorrected, we have deterioration again of the cornea. Here we left either we doing graft or we try to do another touring SK index out the outer part of the previously existing Si5 Kera ring. Here showing how we center the cut. It's centered at the pre-existing Si5, dissecting a little bit that tunnel external to the Si5 Kera ring, inserting the lower one of the index, then the opposite one is quite symmetrical as well, was inserted superiorly. Again, very good results, enhancement of uncorrected, corrected distal visual acuity. We followed this by cross-linking. The patient is around 40 years old. That's why we didn't do cross-linking first. Here's showing the different map of pre-Kera ring, after Kera ring, deterioration of the cornea, and then after inserting the additional two SK index superiorly and inferiorly. Another case of very unconventional procedure in case of severe dermatoconjunctivitis and ectasia. We have had the chance to implant only one Kera ring, Si5 210 inferiorly. After treating the allergy, we have good view for the cornea and good visibility and transparency for the cornea inferior and superior. Then we inserted two intacts, SK 90 degrees, one superior, one inferior, and we get pretty much good result as well. Again, quite mentioning that these cornea tolerated well the 3 rings or 2 rings or 2 adjacent rings without any sign of complication, melting, migration, or inflammation. That would impose a very good question whether we can do further in the ring implantation or not. Here's showing another case of extreme distortion, drop of low corrected distal visual acuity. Here I used the experimental index, which was made to have 303 degrees in a tunnel of 6.8 to 8.3. Here I created a tunnel of 6 internal, 7 external millimeter, and I inserted this ring, which came 360 degrees tip to tip with extreme stretching because I'm inserting the ring into a relatively very steep tunnel. Worth mentioning, as you've seen in the video, that I used the first part to dissect the first half of the tunnel, then I entered from the other half to have an easy insertion of the ring 360 degrees. Well, again, what we have done unconventional is treating the complication, which is ring migration, which is the most feared complication of the ring. Migration leads either to a migration into the anterior chamber when they overlap on the opposite side, or they come to the incision side and they induce melting. Whenever we have migration, we reposition it. If it migrates again, then we go to do the suturing of the ring. Here showing the stages by pulling back the existing ring, passing the first needle and O nylon, then inserting the ring back. We pushed further, and then we put the first needle and the second needle at the desired position where we want the whole of the ring to be, and we can suture the ring. Here showing the picture, and here showing the video how we do it. Here we have migrating ring. We went to pull back the Kera ring using the Sinski and dissecting the pre-existing tunnel. while passing the first needle of the 10O nail, which can be passed easily, though we have to be careful a little bit. So taking the first needle, we push back the ring into the tunnel, but we push further than the desired ring, than the desired position, because I have to enter my two needles. So after pushing further the ring, we pass the first needle to exit, to pass into the tunnel, to exit outside to the stroma, to the surface of the eye, at the desired position of the hole of the ring to be. Again, I was mentioning that when I passed the first needle into the hole, I did not make a knot because I have to bury the stitch after passing it and reposition the ring into place. So here, after passing the two needles adjacent to each other, I make my knot and I can bury the stitch as well. All this procedure has been performed under topical anesthesia while patient tolerating the procedure well, and we have very, very good stability. Removing the stitches not before 1 month after having good fibrosis to hold the ring in place. Here, doing the the knots to hold the ring in place and burying it at the end. Again, unconventionally, we went with the idea of bioring using a biologic tissue taken from a donor cornea, cut at the desired dimension in an outer diameter. I cut it here manually, and then I fashioned the ring to implant into the tunnel of the pre-inserted PMMA where it induced melting. Here we can see the melting side, and here we can see we are preparing the bioring cut at the desired length. We have to make sure that we remove the endothelium and epithelium, and have to be soft as well in absolute alcohol for like 1 minute, then in fortified antibiotic as well. We make sure that it's very well sterile. Here showing the corneal OCT of the biologic ring, which induce a pretty much similar results of the PMMA ring as well. Here the topography of pre-biologic ring and post-biologic ring, which is quite similar, no changes at all. Again, for the unconvention, what we have done is using the hard contact lens to perform cataract surgery in advanced keratoconus. We all know that the optical distortion is quite high in advanced keratoconus. Whenever we come to the phaco, it may lead to complications such rupture of the posterior capsule or irregular capsular rhexis. Here we fashion a handmade hard contact lens. We fashioned to create two edges where I do my insertion. Here showing the anterior capsule visualization with a distorted cornea, and after inserting the hard contact lens, it becomes very smooth. Here visualization becomes quite acceptable. Once applying the hard contact lens, I stick to the cornea by using viscoelastic. Here without hard contact lens, any visualization with hard contact lens. I do the two notches here, which they are drilled using a micro drill, where to put my two main incision for the phaco, one the paracentesis and one the phaco tip as well. All procedure of the phaco were performed quite efficiently without any complication and without any difficulty in visualization of the anterior segment structure while performing the phaco. In the corneal transplant as well, worth mentioning that been said it's very difficult to do the dark procedures after a ring or after cross-linking. Yes, it's true, difficult, but it's quite still attained in our hands 50 to 60% success rate doing the dark procedure following the cross-linking and ring, because we know that they induce quite a significant amount of scar, but we have succeeded to do it in quite significant percentage, 50 to 60% of the cases. Thank you very much.